Ms. Roberts. We are going to be discussing Chapter 15, Care for the Child with a Respiratory Condition. This is in your book on page 492. So it starts talking about the different anatomy and physiology of the respiratory system. So if you think back of the anatomy of the lungs, we have the different passageways of the oxygen. So oxygen passes through the pharynx to the larynx. It's not larynx, it's larynx. That's a pet peeve of mine, larynx, not larynx. Okay, and then of course the air passes through the trachea, down the left and right bronchi, and then it divides into the bronchioles, and then into the air sacs, the alveoli. Okay, so this is the trachea, the bronchi, trachea, bronchi, bronchioles, and then the little tiny sacs, like berries on a tree, are the alveoli. Okay, and this is where the oxygen and carbon dioxide are exchanged. Developmental aspects. We have something in newborns that are called retractions. This is like if you're sucking on a collapsed straw. It pulls inward, the thorax pulls inward. You can see it through the rib cage. And I'll show you some videos in class on what this is. But it is a respiratory distress mechanism. Okay. Our respiratory rates in children vary on the different age groups. Of course, preterm is 40 to 70, newborn 30 to 50, 30 to 60, and then it decreases as we age. So 18 years is 16 to 20. Normal adult is what, 12 to 20, right? It discusses the amount of alveoli at birth. So let's find that. The average full term has about 20 to 50 million alveoli at birth. Okay. As a child gets older, they develop more. So they continue to increase in school age to approximately 300 million by the age of 8. Okay. Lung development is completed at ages 5 to 6. And this is a picture of the larynx, respiration, and pronation. Diagnostic tools, of course, we have pulmonary function testing, ABGs. So just make sure you read through this section. Chest x-rays, of course, CT scans, MRIs, ultrasounds, and these are all used to confirm different diagnoses, such as pulmonary edema, pneumothorax, even pneumonia, amongst other things. There are medication listed on page 496 and 497. Just read through those. And then we're going to talk about atresias and fistulas. Okay, this is on page 498. Esophageal atresia is characterized by a blind pouch. So esophageal atresia is when you have this outer pouch outside of the trachea. It's like a fistula. Esophageal atresia, or EA, with the proximal transesophageal fistula is where it's attached to that esophagus. You'll see that little line right there. EA with distal TEF is where it's not attached up here, but it's attached down here to the esophagus and the stomach, go into the stomach. And then this one has a distal and proximal attachment, TEF. And then an isolated TEF, transesophageal fistula, is here. Okay. The symptoms you would see is cyanosis, respiratory distress, so you may see the retractions and even grunting sounds made by the child, infant, bubbling, frothing at the mouth, inability to place an OG tube to the stomach, choking, so lots of different signs and symptoms there. And here's a larger picture of these in your book as well. This is a child with an ET tube, endotracheal tube. Talks about chest tubes. And then ARDS, acute respiratory distress syndrome. Of course, it's life-threatening. It's increased pulmonary capillary permeability and pulmonary edema. Okay, this causes hypoxia. Alveolar infiltrates. They're filled with something other than air, which is not good, right? They can this can be caused by aspiration, smoke inhalation, sepsis, near drowning, lots of different things. So make sure you read through that. And then patient education on the EAs and TEFs is here. Cystic fibrosis is mentioned next. And this is on page 500. So it's inherited autosomal recessive disorder, and it deals with the exocrine glands. It affects the respiratory, GI, and reproductive system. It's a chronic respiratory disease. It affects 1 in 3,500 births, usually Caucasian population, almost always. Lots of mucus, sticky mucus is produced with CF, excessive salt loss and male infertility even, pancreatic insufficiency. So make sure you read through and understand what cystic fibrosis is. The book does a really good job of describing the signs and symptoms even. But I want you to make note, as a Lincoln Lollipop, the very first sign and symptom you're going to see is a meconium ileus, okay? You're going to may see some prolonged jaundice, steatorrhea, rectal prolapse, but definitely that meconium ileus, okay? So make sure that's the Lincoln Lollipop. Another big thing with infants with CF is failure to thrive, okay? You may see this symptom in those infants. They just have a hard time thriving. Bowel movements may be different than a normal infant. Steatorrhea, even salty tears, salty skin. This is one of the things that we test for on our metabolic screening, like the little blood sample dots on the end of the sheets that we talked about at the beginning of the semester. Cystic fibrosis is one of those things they test for. Your book has a whole lot of signs and symptoms. Make sure you read through these, and then it discusses the diagnosis, okay? Usually a positive history or a trait there. They do a pulmonary sweat test, chest x-rays, and you're going to see that pattern on the chest x-ray, okay? They use the chest physiotherapy. But just to go back and before we move on to the next page, the earliest recognizable sign is what? Meconium ileus. Earliest recognizable sign. And then you have your reportable findings and expected findings. Alright, so let's talk about nursing care. Nursing care, hand washing. Huge, huge, huge with these patients, okay? They have a low tolerance for any bacteria, okay? You're to avoid any persons in the same room with a respiratory infection, okay? Preventing respiratory infections in a CF patient is crucial for their quality of life. So let me say that one more time. Preventing respiratory infections in a CF patient is crucial for their quality of life. Okay. They do CPT, which is the chest physiotherapy. Okay, this is here, and that's what this is. Okay, performing the percussions and vibrations, and then they have the jacket that they put on, and it just kind of shakes that mucus loose. Very important maneuver for these CF patients. Another wink and lollipop for CF patients is to make sure you understand that we have to give them a replacement of their pancreatic enzymes. Okay, their pancreas does not function well. They have a complete loss of pancreatic function and inadequate digestions of proteins and fats. So we must replace these pancreatic enzymes for them to be able to manage their care, manage their bodies, and for us to manage their care. Okay. Digestive enzymes are mixed with their food. We replace those with snacks and meals. There's another picture of this CPT. We need to loosen those secretions, and sometimes we would need to suction them if they're unable to cough. This is just a breakdown, another picture of CF. This is sticky mucus, blocks the airway. It's so thick and sticky. They have a hard time coughing it up sometimes. So that's why the CPT and the vest that shakes them is so important. Okay, and this just kind of walks through. They can be cyanotic. They have a hard time gaining weight. So we plan high caloric intake for them. Okay. Another wink and lollipop is to instruct them about prophylactic antibiotics, medicated aerosol therapies, of course, the deep breathing exercises, the CPT, because this helps reduce the atelectasis and promotes healing, of course. Okay. I want you to know these in order. Okay. So, number one, we're giving them prophylactic antibiotics. Number one, know these in order. Then we're doing the breathing treatment, medicated aerosol therapy. Okay, so we put the antibiotics on board, then we give them the medicated aerosol therapy, then we do the CPT as the third step, and then we do the deep breathing and cardiovascular exercise. Okay, so in order: antibiotics, breathing treatment, aerosol therapy, inhaler, breathing treatment, whatever. CPT is the third one, and the last one is deep breathing and cardiovascular exercises. Okay, so there's a madness to why we do these. We get this on board, we give them the albuterol or whatever, LABA or SABA is indicative of their treatment on board, and to use that, that helps dilate everything, bronchodilators. Then we do the therapy to help break it up, and then we do the breathing exercises. So if you do it in that order, it will work correctly. Some more on cystic fibrosis, and again, there's that meconium ileus, right? Pancreatics information, they just do not function. Okay, they have a high risk of gallstones, inflammation of the gallbladder. They usually have to have a cholecystectomy young, and then the reproductive system. A lot of times the men are infertile, but they do have normal sexual functions. And integumentary, lots of salty skin. They do that sweat chloride test. So make sure you understand all of that. Okay. Then upper airway disorders, rhinosinusitis is mentioned in your book. Make sure you read through that. And then pharyngitis is also mentioned. For pharyngitis, let's talk a little bit about that. This is the mucosa, inflammation of the mucosa in the pharynx, okay? Pharyngitis, obviously inflammation is the itis part, right? You're going to see sore throat, difficulty swallowing because of the edema there, fever, lymphadenopathy, swollen tongue, tonsils, pharynx. So usually subsides within 3 to 5 days, unless they get some type of peritonsillar abscess. Of course, we're doing a culture to see if it's strep or not. So you just swab the back of the throat. Now let's talk about tonsillitis. It often occurs with that pharyngitis, okay? Some lymphedema is noted. Progressively happens between 2 and 10 years old. Let's go back up here. With that pharyngitis, make sure you're educating them, okay? Educate them on what to do. This is a wink and lollipop. So make sure they get that full dose of antibiotics. Not when they start feeling better do they stop it, but they must finish it. And then you can use Tylenol and ibuprofen, acetaminophen, ibuprofen, and a cool mist humidifier to help them feel better, okay? It's important, it's so important to make sure they finish the antibiotics because this can prevent heart damage, okay? We see all kind of things, and we'll talk about that later when we talk about cardiac, but pharyngitis, sore throat can cause some heart damage, okay? All right. So tonsillectomy. After the surgery, wink and lollipop, we are going to provide comfort measures, of course, right? They are kept on their side. Make sure you understand that. They're kept on their side to facilitate the drainage of secretions. We do not need them aspirating on blood after a tonsillectomy. So they are kept on their side. Coughing, clear, and blowing the nose should be avoided. We don't need any more pressure on there. We need to let them heal. Okay? So wink and lollipop, keep them on their side. And of course go through these discharge instructions. We'll listen to this creepy cough in class. But croup, generic term for the illnesses of the larynx, trachea, and bronchi. Okay? Kind of sounds like a seal barky cough. Okay? Has some signs and symptoms, but wink and lollipop, you need to know the signs and symptoms of croup, okay? A barky cough, hoarseness, sudden onset of fever at night, okay? Do you know what coryza is? Coryza, this word right here, is rhinitis, or a stuffy nose. So if you don't know what that word means, just make note of that. It's rhinitis or stuffy nose, okay? Congestion. But this is a harsh, barky cough. Very harsh, okay? And there's just some more information that we discussed. All right, so let's talk about croup versus epiglottitis, okay? So with croup, you're going to see a sepal sign. That's one of the biggest things you're going to notice. Let's go on down here. On page 506, it starts talking about the epiglottitis. So with croup, it's the steeple sign. With epiglottitis, it's the thumb sign. So you see how this is so much edema up here in the larynx and the pharynx, starting in the bronchi, it makes a steeple, the steeple sign, because of the edema. The epiglottitis is a thumb sign, so it looks like somebody's got their thumb on that x-ray. You see it right there. This should say not epiglottis, this should say epiglottitis, okay? Very important. Make sure you understand that. This is Wink and Lollipop, this Nursing Insight. Stay over. Okay. So Wink and Lollipop, understand that a classic sign of acute epiglottitis is when the child sits upright in a tripod position, okay? With a chin thrust out, like the sniff position, like they're going to sniff their nose, okay? Breathe in. But classic sign is that tripod position, Wink and Lollipop, okay? Then they're going to have like a frog-like sound, croaking sound on inspiration. They may have some drooling even. So the drooling and the frog-like croaking sound here. Very important to know. We encourage our before I say that, let's go here. This is your steeple sign that we just talked about, and then your thumb sign, okay? So make sure you know both of those. Steeple sign is for what? Croup. Thumb sign is for epiglottitis, okay? Then our focus on safety. Another Wink and Lollipop. You never, ever, ever try to intubate somebody with epiglottitis, okay? Wink and Lollipop. No tracheal intubation, okay? It can occlude that airway. So do not attempt to visualize the throat with a tongue blade, okay? It can cause a laryngospasm, and you can cut off their airway, and we do not need to do that. Some more information on epiglottitis. Collaborative sign, collaborative caring, I'm sorry, is to reduce their anxiety. So we encourage, because what happens when a baby gets anxious, they start crying. Do we need a baby with epiglottitis to cry? They're already probably having some laryngospasm, some edema, obviously, so we don't want them to cry. We encourage, as nurses, we encourage those parents to stay at bedside, okay? We want to keep the child as calm as possible, okay? So Wink and Lollipop, encourage parents to stay at bedside, okay? Very important. RSV is next. So let's go to page 508. Talks about some bronchitis. Let's talk about RSV, respiratory syncytial virus. This can happen in infants. Very common in preterm infants. That's why we encourage them to get that RSV vaccine. Okay. RSV infection results from a weak antibody response. So we encourage that. Some signs and symptoms that you may see, Winks and Lollipops, are retractions and rails on the expiratory phase of respirations, and decreased appetite and poor feeding. Okay, important to know. And then some diagnosis. Of course, we test for the virus, swab to test for the virus, and then nursing care. Obviously, we got to keep them well hydrated, well oxygenated. Wink and Lollipop, make sure you understand that. Hospitalization is recommended, especially if they have a other debilitating illness, or a chronic issue. Okay, so we're watching all of this. We're watching for oxygen saturation, keeping the O2 sat on them. We're keeping the head of bed elevated to at least 30 to 40 degrees. We're using a cool mist humidifier, maybe even an oxy hood or a tent for O2 concentrations to alleviate the dyspnea and hypoxia. And see here, I want to say we need to institute cluster care to encourage adequate rest for these patients. Okay, they don't need to be somebody coming in every 5 minutes. You know, cluster care. Go in with respiratory. Go in with a provider. Do what you need to do, and get out where they can rest. Of course, hand hygiene is so important. All right, on page 510, let's talk about pertussis. There's pneumonia. Goes hand in hand. Pertussis, okay? This is a droplet infection. Very, very, very contagious. Lincoln lollipop. It is a droplet infection. Okay? It spreads via droplet. Direct contact with discharges from the respiratory mucous membrane. Okay? Droplet infection. Read over their different stages of pertussis and what can happen with that. There's some pictures of the allergic shiners in patients. You may see that. Let's talk about that on page 515. There's Tamiflu that's mentioned, of course. Foreign body aspirations, and then we're going to talk about allergic rhinitis. Very common in South Georgia, obviously, right? Where everything blooms and all throughout the year, okay? But these are allergic shiners, the dark periorbital swelling. You'll see kids with this all the time, okay? But that's what it is. They're allergies, just that rhinitis, that swelling there in the dark underneath their eyes. All right, let's talk about asthma. Huge thing in children, right? Most common chronic childhood disease. 3.5 million children suffer under the age of 18 every year. Okay, huge numbers. I'm not going to highlight it, but this right here, okay? I do want you to know these signs and symptoms. So, winks and lollipops. Signs and symptoms of asthma, okay? Recurrent wheezing is huge, okay? This is that diffuse wheeze. It doesn't get better. It gets tighter and tighter and tighter. This is spacer for breathing treatments, breathing the breathing treatment mask over here, but the spacer for the inhaler. This is an asthmatic airway, lung airway, and this is a normal one. You see how the tissue is swollen. A lot of kids have exercise-induced asthma, so only when they're running outside do they have trouble breathing. So make sure that they keep their inhaler with them, okay? But winks and lollipops know these signs and symptoms. Prolonged expiratory phase, non-productive cough, that's a huge one right there, okay? Non-productive cough. So they have that wheezing, non-productive cough with asthma, okay? So what sport are we going to suggest for our asthma babies, okay? Swimming, okay? We're going to encourage swimming versus any other sport because it's low heart rate, low exercise as far as the breathing. You hold your breath to swim, and it's not like playing basketball where you're running up and down the court or football. So we're encouraging, I know it's not right here, but you can write it in your book, encourage swimming, okay? then it starts talking about the severity of, on page 518, and the classifications of treatment, okay? So you have your SABAs and LABAs listed here. That's your short-acting and long-acting beta-2 agonists. So make sure you read through that, and then your management guidelines are listed here. And then there's an action plan in your book. It even talks about COVID in here, okay? But there's a American Lung Association action plan. All right. And that is the end of chapter 15.